Families theme webinar. And we are really pleased to be having three great speakers today who I will introduce to you shortly. Before we get started, just a quick reminder of why we're all here. So the Children and Families DSxHE theme is specifically focused around social, environmental and structural contexts which affect children's health. And we are really interested in looking at also the families, caregivers, siblings and systems in which children are within, and using data, how data is used to understand this. We have four main aims. So the first is to promote health equity in families, children and young people, and to create a supportive, collaborative, data-driven approach that considers the child within the context of the family and the wider environment. We really want to connect researchers, clinicians, policymakers and experts by lived experience, and create a platform where we really share knowledge and facilitate engagement. What we really want to do is build community that amplifies voices and ensures that families and children are looked at in an equitable way, and we use data science to understand these conversations. We have three great presenters today. So we'll be starting off with Joe Lang, who has done a lot of public engagement work in families and children, and he'll be talking to us about that today. So Joe, I will stop sharing and then you can share. Stop sharing.
Can you see my screen okay? Okay, wonderful. And this is for about 10 minutes, right, Selena? Okay, perfect. Um, well, welcome everyone. I'm Joe. I'm really happy and honored to be able to share a little bit of most of my reflections. I can't, these are principles that I live by, trying to work with co-producing with children and families in health data research. These are by no means the one and only truth in this universe, and I am also very highly, well, my suspicion is I'm preaching to the choir here. Like most, if not all of you, would have known a lot about these without me needing to say them. But hopefully my brief introduction today would set the scene well for the rest of the hour and to reestablishing why and how we work with children and families in health data research, in particular for health equity. So, quick audience interaction. Um, if you're London-based, has anyone heard of the four plinths in Trafalgar Square? Quick raise of hands. Yeah, I got Vish the Londoner nodding, and that's good. So the four plinths in essence are the sort of people that the British people celebrate in history or as like figures in human society, in British society that are highly valued. And there has always been a sort of contending vacancy for the fourth plinth, just on the corner of the Trafalgar Square. And there has been several contenders and things changing. And the Mayor of London started an initiative, I think 2 years ago, which is really beautiful, which they asked children to submit their artwork to be molded into an actual plinth to be celebrated at Central London, at St. Martin's in the Fields, such that they want to capture the contribution, the livelihood of young people and their contributions to our modern society. And these are temporary setups and obviously no longer here. But I hope this sets the undertone of the presentation today that um, in health research, if we consider and treat children and families as a key mode of knowledge production, it would materially change what we build, how we measure, and knowing our common flaws and what we claim. So we in data science, we're often quite prone to a quiet assumption that our real work happens in our code and models, and engagement is only a way we try to explain it afterwards. But hopefully today, from myself and other people, we try to flip that playbook and say, if your work affects children and family, then they have a valuable role in shaping the questions, the trade-offs, the definitions, and not just their reaction to the final product. Um, so these are my principles that I live by. First, we treat children and families as domain experts in the lived system. Um, so I think we are a bit privy in this area as data scientists. We can easily say that, oh, we do so much better than the basic scientists, as in we no longer treat co-production or public engagement as a task that is enforced upon us, but something we see value in. So we've long moved away from the thinking that there's nothing children perceive that we adults don't already know. In families, we also think that we no longer believe that there's nothing that the family perceive that us researchers don't already know. But the last one might be a bit tricky, that we sometimes do have to resist the assumption that there's nothing people perceive that the data don't already know. So what I'm really pointing to is this sort of techno-theocratic framing of data, that data is the one and all, the absolute observer, the oracle that tells us all we need to know about everything. So in data science, we use proxies a lot. It's full of proxies. When proxies don't work, they don't fail randomly, and they fall along the lines of sort of power, resource, confidence, language, and how we interact with the system. So well, this is an exercise. One of our colleagues, Vincent, always helps us think through this problem. So, what has to be true for someone's record to show up in health data at all, if we are talking about hospital admission? So, who has to notice that problem? Who has to believe it and to record it, to phone in, fill forms, travel, insist, bargain with the system to make sure that's recorded? And what stops people from engaging in the first place? Like poor experience, fear, stigma, cost, exhaustion, immigration concerns, and what happens after a record is in the system, right? What does a referral mean? And does that mean you get help? Or does that mean the referral is just rejected? And does missing an appointment meaning you're disengaged, you've moved to somewhere else, or it simply means you've recovered and no longer needs the service? So take childhood cancer, a quick example that Selena and I have been working on. Um, Administrative data, health records can be pretty strong in understanding diagnoses, treatments, hospital use. Uh, but the families would tell us that there are other things that's not being readily captured in the data, right? Something about their interaction with health systems, reintegration in schools, mental health constraints, how these effects are distributed differently across households or families with different levels of income, and other phenomenon, symptoms, experiences that are not severe enough or recognized enough to make it into the system. And it's not just about sort of secondary mental health data or cancer related data. It's also about other types of study design, right? And there is for example, if we are designing an intervention in family and children, and if we only found out after 5 years that the intervention didn't work, and the reason for it not to work is because it's simply not in a way that's digestible, deliverable, or meaningful to parents, then it's simply 5 years of wasted resource that doesn't really help us move anywhere. So fast, we treat children and families as domain experts in the lived system. And number two is my second principle is about trust, that trust is the infrastructure of knowledge, and knowledge generation is almost always relational. So these are some of the pictures and art really produced by a group of young people that I've worked with Quorum Citizens. Um, the group made up of people from migration and refugee backgrounds and living in the UK for between 3 to 13 years. And the workshop focused on going into their community and trying to explore what ethnicity means to them and how does that data is being represented in sort of our administrative records and help us identify whether those representations is a good fit for their experience. And I quickly realized what I'm asking of them is not simply them telling me what they think, but taking a part of them and help me how to make that piece of story meaningful and really vital to their actual experience. So we are asking a lot of our participants, our families and children when they decide to work with us. And this trust is so key in not just shaping what we can know from them, but how to convey disappointment. And that's a constant struggle in health data research. There are things we simply can't change. There are things that our research questions won't be able to answer. There's something that the grant giving body don't think is the priority so far. And how do we communicate this in a way that's conducive and keeps people engaged and find value is important, and trust is foundational to that. And finally, my third principle is to honor and celebrate children as they are now and not as a future potential of who they may become. Um, when we say we honor children as they are now, not as future adults, we're also saying something practical. That the time, emotional labors are not ours to spend and spare. If children are full adults, full people now, involving them can't be an extractive one-way transaction where we simply take what they say and convert it into papers, products, dashboards, and never go back to them. That's what non-extractive means, right? It means designing means of engagement so that children and family retains agency over what they share, how it's interpreted, and what happens next. So there is a need for a visible return, how our decisions made, harms reduced, capabilities built. And tightly related to that is to be creative, right? So these are all sort of the different outputs and things people that I've worked with, we've made, we conjure up different ways of celebrating how they can build in their feedback and thoughts into the work that I produce. So with art, with materials for public engagement, with podcasts, written boards, blogs, publications. So just hope to showcase a few of the things that I'm involved in, but I'm sure there are plenty of others. Selena and Katie, my supervisors, working very closely with a young person to help them elevate some of their work and science that they've been doing on the side. And so all of these are hinting to us as data science people to think more creatively in how we close the loop, right? So I think that the social science people are doing it really well to close the engagement loop, but in data science, we still tend to sort of doing it less well in terms of finding more creative or meaningful ways to celebrate them being heard. Um, I want to read out this extract from Lucas. So Lucas is this year's winner for the fourth plinth of the Lyndon Mayer competition. And this is his work, It's Gonna Be Okay. So this is from his interview. I was having Chinese food with my family, and my fortune cookie at the end of the meal had a very cryptic message in it that didn't make any sense to me. So I thought, why can't it be something very simple, but something that would make you feel good? So Lucas made this as a child, and he didn't read for something cryptic or try to conjure up some big words to explain why he made this piece. But I think he's pointing to something clearer that's not naive, but is demanding a level of legibility and has a great importance for us working with health data science. I think it helps us understand that co-production, public engagement isn't about making ourselves feel good, and it's about how we produce knowledge that holds up in real world settings by making assumptions visible, naming trade-offs, being accountable. Simple, in that sense, is the standard so that children, families can understand and can be told what's happened. So harm, even unintended, aren't hidden. inequalities in particular isn't shoved away behind complexity. And that's how I think we can make health data science more valid, more equitable, and accountable. So thank you, Lucas. And thanks, everyone. That's the end of my sharing.
Thank you so much, Joe. Thank you. If you have any questions, you can put them in the chat or you can put your hand up. If you're happy to put your hand up, I'll come round and have a look, or you can put them in the chat. It's completely up to you. While people have a think, because is there anything in the chat dish at the moment? No. While people have a think about questions, I've been thinking a lot about this kind of, and people often ask me, Joe, about like, it just seems like people are doing PPIE or co-production, and like instead of doing qualitative research, like should this be a qualitative study that you actually look into, or are you basically just using this? So what's your kind of thinking around that?
Yeah, I think those things are different. Um,
Yes, we know.
in,
Yeah.
yeah, you would obviously know. Qualitative research, it's there are some shared similarities, and there is this assumption that good qualitative researchers would automatically do good public engagement and co-production. I think there are some skills that overlaps about active listening, about how you work with people. That is key for both. Um, but there are also some key differences, and in this sense, there's a need to differentiate co-production from public engagement as a wider term, right? Public engagement can happen at different stages of research, and there are suitable ways. And I wanted to say this: not every piece of work needs to be co-produced, and not everyone needs to know everything about everything. And so it's about finding the right places for these different types of design ways of working to fit in. Um, and yeah, maybe I'll stop there and we can continue this in a different setting.
No, just it's good to get everyone's thoughts. Any questions in the? I can't see anyone's hand up. Row.
Thank you so much, Joe, for that presentation. And I think bringing on a little bit about what Selena mentioned, as well as your presentation, I was just wondering if you've thought about this whole ecosystem of knowledge, because I know you said like the social sciences are doing a lot of good work in terms of following these principles, but I'm wondering what we can do also for funders and
Mm.
government to want to incorporate these types of things in work. We know that certain
Yeah.
funders are pausing and it's a complicated thing. So I wonder if you've had done any thinking on that.
Yes. That's a very good question. So I won't be able to give you a satisfactory answer here in a minute or two. I would point you to this other conversation I'm very fortunate to be involved in on a panel that I discussed with other members of PEDRI and other contributors in the data science space, and what can build this cultural shift in making public engagement sort of not a one-off task and more central to what the fund is and other directorates' priority. And funding is absolutely a part of it, and we have seen how, sort of, for example, NIHR Engage, how that framing has helped ensuring public engagement is key in sort of being recognized in NIHR relevant proposals. As a member of the Health Research Authority Research Ethics Committee, we are seeing the last year that all ethics approval applications now mandate a section in about public engagement and involvement. So I think that there are, well, if I may, like different universities are also starting to have like designated structures or organization around um, supporting researchers and using co-production and other relevant techniques in their work. And so what I wanted to say, it's often about how different parts of the puzzles would contribute together in shaping that need. And I think this is a role us as researchers can play, is to keep on emphasizing that this is not a tick box exercise and to showcasing the actual added values to our work, but also to our participants, um, and hence shape the landscape and carve out the resources um, for this. But no, it's not a 1 day or 3 year project. It's much longer, bigger scale. Needs everyone to work together.
Any other questions from anyone? Thank you so much, Joe, for sharing all your experiences, and I'm looking forward to hearing about everything you're going to be doing with Pedri as well. It seems like, you know, everything you're talking about is so relevant to us and our work, because we can sometimes just really feel like it's all reduced down to numbers, and it's so important to know about the context of families, and actually families inputting into research that's about them, and young people as well. You know, it's research about them. It should be done with them rather than about them. So thank you so much for coming and sharing with us today. Okay, so our next speaker is Louise. She's a research assistant at UCL, and her research focuses on health education of young people with neurodisability using the eChild dataset, which I'm sure she'll explain.
Sorry, just a minute figuring out how to present in Zoom.
Every time I'm switching from to Teams, I'm like, where is everything? In fact, today I was like, where is my camera?
This is going to work. Does that work? Can everyone see?
It's about to come up, I think. Yes, we can see it. Thank you.
Okay, great. Hi, I'm Louise, and today I'm going to talk about a study using linked data to examine health and education outcomes for young people with neurodisability, and what we've learned from involving young people, parents and carers, and how that shaped that work. So this, I guess, is an example of a study that could technically be done without involvement, but where involvement has made the work more relevant and better grounded in lived experience. So I'll start with a bit of background on the study. So what is neurodisability? So neurodisability in this study refers to a broad group of long-term conditions affecting areas such as movement, cognition, communication, and behavior. It's a very diverse group of conditions, so including things like autism, learning disability, epilepsy, and cerebral palsy. And around 1 in 25 primary school children in England have a hospital-recorded diagnosis. Adolescence is a particularly important period for young people in general. So it's a time of rapid development, increasing independence, and multiple transitions across education, health, and social care systems. And for young people with neurodisability, the support needs can often change quite quickly during this time, and moving between child and adult health services can be difficult. And this can lead to disrupted education through higher absence and exclusions and high levels of healthcare service use and gaps in continuity of care, particularly around transitions. So the aim of the study is to overall is to examine how health and education support and outcomes change from adolescence into early adulthood among young people with neurodisability compared to their peers without. And specifically, we're focusing on patterns in special educational needs provision and planned and unplanned hospital care and school absences and exclusions. I won't talk too much about this, but to do this, we're using the eChild database, which links health and education records for around 20 million pupils in England. And so these data allow us to see what's happening across systems and over time, for example, patterns of service use and school absence, but not why those patterns are occurring or how people are experiencing them. And that's where involvement from young people and parents and carers becomes particularly important. So a bit about how we've involved them in this study. So our research questions are grounded in themes that came up from earlier advisory group work with young people, parents and carers as part of the health outcomes of young people through education programs, also known as HOPE, which focused on the health and education outcomes for primary school aged children with neurodisability. And early on in this study, we met with the HOPE Parent and Care Advisory Group and the Young People's Advisory Group to revisit some of the themes that they talked about in the context of adolescence and secondary school. And the discussions focused on SEND provision, how to measure health and well-being within the data, and navigating transition points across education and healthcare. So my role in these sessions was primarily as an observer and contributing where appropriate, and then using these discussions to inform how we approach the study. So what did we hear? So from the earlier HOPE program work, which, as I said, focused on primary school age children, young people and parents and carers consistently highlighted that adolescence is a particularly challenging period. So these insights directly motivated the focus of this study on adolescence and secondary school. And then in the 2 advisory group meetings specific to this study, we discussed what SEND-related support is available during secondary school and what we might be able to measure in linked data to understand how helpful that support is for health and well-being. And participants described long and difficult journeys to securing diagnoses and appropriate support, with emotional and mental health needs often overlooked in favor of things like behavior management, like including suspensions and exclusions. And they also highlighted that withdrawal from schooling can contribute to mental health crises, and that there was insufficient support when returning to school after health-related absences. And there was also some stuff came up around difficulties around exams and changing schools and different transitions, so especially from pediatric to adult healthcare and mental health services, and that these were times when support often feels like it falls away. So these discussions helped us to clarify which health and education outcomes were important to focus on and how patterns in the data could be interpreted. But of course, some of what came up in the discussions isn't directly measurable in the data that we have. So, for example, young people emphasize that the type of SEND support that they receive matters, and parents and carers talked about how the provision isn't always implemented consistently, even when it exists on paper. But while we can't capture the level of detail, that level of detail in the study, those insights are still helpful for understanding, what recorded SEND provision, absences or exclusions might actually represent in practice. So how did that shape our study? So kind of in 3 main ways, I guess. So first, it can help the analytical focus. So as it, reinforced that adolescence was a period of time that should be looked at, especially across these specific transition points, such as entry into secondary school and from pediatric to adult healthcare. So that informed our age-specific analyses and our focus on periods such as that. So it also helped us with outcome prioritization. So although absences and exclusions were already included in our study proposal, discussions with young people and parents and carers emphasized, things like their close links to mental health and unmet support. So it helped to reinforce our decision to examine them, absences and exclusions, and prompted us to also include indicators of mental health need that we can identify in hospital data. Obviously not all, but some. And then it will also help us with our interpretation. So, participants highlighted things like patterns such as rising absences or exclusions are often linked to gaps in support, poor coordination between systems, or difficulties at transition points, rather than being explained solely by individual behaviour. So that will help us to inform how we can plan to interpret the quantitative trends that we see and frame conclusions. It also kind of reinforced the need for caution. So, for example, as I said, recognizing that recorded SEND provision doesn't necessarily reflect the type or quality of support that a young person receives. So involvement is ongoing. So we plan to share the findings with young people, parents and carers, to kind of sense check whether our interpretations align with their experiences and to understand where the data may be missing important context. And that will also help refine our interpretation and guide dissemination. And the discussions we've had so far have also highlighted important questions that can't be fully addressed in this study, which will hopefully shape related work using other methods in the future. So I guess what have I learned from this? I guess key learning is, involvement makes kind of work with large linked data sets more relevant and better grounded in lived experience. Administrative data can show us what is happening over time, but the lived experience helps us to understand why those patterns might emerge and where caution might be needed in interpretation. And that even in large studies with predefined aims and outputs, involvement can still help shape those studies. But at the same time, I guess one of the biggest challenges that I find is how you do integrate those insights as fully as I would like to within the constraints of a study that has largely been predefined, where the aims and outcomes are largely predefined already. And kind of, as Joe was talking about, like how much the data can tell us, as it doesn't always reflect the nuances of the experiences that we're trying to understand. And that's it. Thanks.
Thank you so much, Louise. I'm just going to open up to see if anyone has any questions before I come in with my thoughts. Is there anything in the chat? No. Okay, I will come in with my thoughts then. What you said at the end there, I really resonated with, that to get this money and the funding and everything, we have to be so clear about what is your exposure, what is your outcome, what exactly are you going to do? But then, so it's so predetermined. And then like when we're doing then engagement or PPIE, it's kind of like, we want that and we want to know what their perspective is, but it can be quite tricky, like kind of also communicating, like, I'm not going to be able to completely change this. And something that we found that was quite tough was that like a lot of things came around lack of support and really like wasn't measuring that. So it's kind of like just thinking about, how do you go about managing that? And like when you're doing PPIE.
Yeah, I mean, is that a question how I go about? Yeah, I guess that's the part that I find quite difficult. I mean, I guess there's something in when there's expectation setting when you're doing PPIE with whoever you're doing it with, I guess, and trying to help them understand the constraints of the project. But I guess, yeah, I mean, I do find it very difficult with also then, so that they don't feel like what you're doing is just performative or tokenistic, when you're kind of saying, we really value your input, but also there's only so much we can do with it. And hopefully this might help in the future. But so yeah, I guess I don't have a good answer for that. But it's something that I find challenging.
There isn't any answer, because it's kind of like, and I was talking to also Pedri about this as well, like, because I know they've implemented it all like in their kind of in the forms and stuff, they want to get it into ethics. And, it's kind of like including PPIE right at the beginning of studies or when we're conceiving them is one way of going about it. But then there's like this whole thing around having funding to do that. So it's quite tricky, and you've done a lot of work on this and done it so well in your study, and it's really shows that it's been integrated. So thank you for sharing that.
Thanks.
Any other questions from anyone? Silvana?
Hi, thank you so much, Louise. That's so interesting. I kind of also work in the area of neurodisability, and I have more of a practical question, if you don't mind. So what's been your experience in terms of working with parents and young people? Do you usually tend to do that together or separately? Because I think like it's something that often comes up for me, and I'm never quite sure what's the best approach.
Yeah, I'm not sure it's the best approach. No, we've done it separately just because we were lucky to have access to these groups that were kind of set up as part of the Hope study. So we had parents and carers group and then a young person group. I guess I do find, like, I think maybe with young people, there's no basis for this necessarily except my own thinking, but I think, doing kind of having a separate discussion with young people, I feel like could be helpful. They might feel more freely open to talk about things than if they were with their parents, and certain things they might not want to say. But obviously then there's building a level of trust that they feel safe and okay to do that in a space with a stranger, essentially. But yeah, we were very lucky to have like a researcher who ran the sessions, and we had those kind of groups set up already. So yeah.
Yeah, no, great. Thank you so much. That's kind of been my approach that I ended up doing as well, kind of running them separate, but I kind of want to hear what approaches other people are taking. So yeah, that's really interesting. Thank you.
Thank you for that question. It's something we thought about as when we decided to keep it separate as well. And the learnings were very different from the young people to the parents, actually. So yeah. Any other questions from anyone? Anything in the chat? Okay. Thank you so much, Louise, for sharing all that. It's really, really well-designed study with PPI included in with the young people and parents. Thank you for sharing. So next we have Julia, who is a third-year PhD student and research assistant at UCL, studying the relationship between education and health among pupils with Down syndrome and other neurodisabilities. Thank you. We can see your slides.
And you can hear me talking. Okay, hold on. Okay, this is better. Okay, so I'm going to give more of a, I guess my approach is going to be a little bit operationalized in like the step-by-steps that I've followed to set up PPIE. Because I find like sometimes, for me at least, as I've been figuring it out during my PhD, this was the first time I've done any PPIE. And I felt like I was flying a bit by the seat of my pants and just figuring out what I was doing as I went. So this is public and patient involvement for not necessarily for dummies, more by a dummy. And I'm going to walk you through what I've done and what I figured out and kind of share some of the findings I've had. Oh, let's see, click. Okay, so public and patient involvement is very popular. Everybody loves it. We hear a lot about it, but why are we supposed to do it? So in my experience, here are some reasons why it's really, really helpful. So it strengthens your research. And I think this is kind of goes to the question that was asked earlier about how public and patient involvement differs and can differ from qualitative research. In public and patient involvement, rather than going in with specific questions and designing it carefully, you can help them give you questions. You can go to people and help them make sure you're asking meaningful questions. You can go and present some results and get context for your data and say, what do you think it means? And you can get an interpretation of your results. So it's just so helpful to be engaging with the audiences who will benefit most from your research. Another benefit of public and patient involvement is that it builds public trust. So this is important for a few reasons. Like one, when you have the trust of the public as you conduct your research, then when you have findings, there's already an audience ready for you to disseminate to, and they already trust you and they want more of your research. So then they often, even as you talk to the public, they sometimes help you come up with action items that you can write into your papers, you write into your grants. So it kind of ends up being this feedback loop where you come to them with a question, they give you more questions, you get results, they give you meanings, and you continue to get further research and further opportunities for PPIE when you build good relationships. Okay, so then how to organize PPIE. I'm just going to talk about what I have done and what I have found helpful. So the first thing, as you'll see from the picture on the side, you should work all your angles. There are a lot of different ways you can come at PPIE. And I personally have found it beneficial to really come at it from every angle I can and take advantage of every opportunity. So I'm really fortunate that my research is funded by the Down Syndrome Association. But if you're funded by an organization that's broader, you can still find advocacy organizations that work with your subject matter or your population of interest, and you can kind of partner with them as you go. So I've been really fortunate when I've reached out to the Down Syndrome Association. I've been able to say, hey, I'd love to meet with parents. And first they helped me go to a parent support group. But then I found the parents I met with at the support group were mainly from one demographic. So then I went back and said, now I'd love to meet with parents from other regions. Now I'd like to meet with low income parents. And they just kept helping me make it happen. In addition, they gave me opportunities, to put an article in their newsletter, and then parents reached out to me. So it started to be a situation where I was kind of bombarded by opportunities for public and patient involvement, which was great. Another opportunity that I don't think I can stress enough is materials that are already made by our audiences. So the Down Syndrome Association, and actually several Down syndrome advocacy groups, they make materials for each other, for themselves. And you can go and watch those videos where maybe it's not for you, for researchers, but it's for youth with Down syndrome or parents of children with Down syndrome. But you hear all these amazing stories. And suddenly you've done a ton of PPIE and learned a lot of things without leaving your room. Really, you've just got to hear all their stories, which is great. The other thing is sometimes they'll have online events or focus groups. So I've been able to attend online policy discussions where parents were just venting about policy changes. And I got to hear everything and didn't have to ask questions. I just got to show up and they appreciated that I was interested. And yeah, attending presentations and reading presenters' books and articles. I just wanted to share. I might need to unblur so you can see this. How do I unblur real quick? Video. Blur my background. So I'm just going to share. This is a book that was published by the Nottinghamshire Down Syndrome Support Group. So they put this together for families who have a baby with Down syndrome. They give it out in the hospital, but it's amazing. It really tells all these different health and education stories about children with Down syndrome across different age groups. And it's so helpful that they've already written the stories. Sometimes I think it's important when we're doing PPIE to take advantage of people who have already spoken. Often the stories are out there. I just wanted to share one cute thing. So I brought this book home from a conference, and my 7-year-old daughter got a hold of it and is now obsessed with Down syndrome. All her dolls have Down syndrome. And this was for Hanukkah, all she wanted was a doll with Down syndrome. So Down syndrome has become a big part of our lives, which kind of goes on to my next thing here. I'm going to re-blur. Let's see, is talking to people after your own presentations. People will come up to you, but also in your day-to-day life. And this is quite informal, but I have found it so useful. There are opportunities for PPIE. So, I'm a bit privileged that I do a school run. So I talk to moms all the time. I have children or, mom friends who have kids who will tell me their experiences. But also, just throughout different places you go, often there will be people, friends who have a sibling who has an experience, and these can be really powerful. So just for an example, some of the research I'm doing right now looks at Down syndrome as well as other neurodisabilities. And I was recently at a family funeral where a woman I didn't know happened to mention she had a child with a disability. So I asked her about it. This was even in the United States. And she said, oh yeah, he has cerebral palsy. And I just asked, what do you wish people were asking about that? What research would you like conducted? And she said, support. No one is talking about how much support families need. It's what makes all the difference. It's not, it's not even necessarily the medical treatments. It's not, it's not funding or, it's not a lot of things that we think of. It's just how it's the support workers. It's having a person there to support the family. And it was interesting to hear that this was the same story I've heard in different regions across the country and in other countries. So just taking advantage of every opportunity you have. Okay, now how to conduct PPI meetings. So this is something that as you plan, it's just helpful to have a game plan. So what kind of meetings? You can do groups, you can do one-on-one, you can do quite informal. But the most important thing when you do a meeting is to set people at ease. And I think the best way to do that is to bring food. But I think another important thing is to plan in advance an elevator pitch. Let's see if it works. Sometimes it shows an ad first. Hopefully you don't have to watch an ad. Oh no. Okay, I'm so sorry. I'm really not good at tech. We'll get through it quickly. And then it's a really good Okay.
You sound like you're ready to become your own boss in the exciting world of frame nudging. Yes, for a minimal franchise fee, you'll receive a pair of straightening gloves, a canister of wall lubricant, and a booklet of the most commonly asked questions you will hear, including who are you and what are you doing here?
Okay.
Folks, I don't want to alarm
Escape. Well, let's move to the next slide. So, okay. That actually is that's one of the most important things to be able to answer is who are you and what are you doing here? And I found it's often really helpful, when you're in a focus group or something, you don't necessarily want to show slides, but it's helpful to have a handout that is maybe just a slide that says, here's my research, here's what I found, and here's who I am and what I'm interested in finding out from you. And while it's really helpful to come prepared with questions to ask, it's also really helpful to be open to where people want to take the discussion. And I find, when you have like 20 minutes left or, you've kind of exhausted what you were asking about, I just try to make sure I leave time to say, is there anything that we're not talking about that we should be? And sometimes it can be a big surprise. This is how I found, for example, the travel to school that children in special schools often experience, which was something the Down Syndrome Association actually hadn't been aware of how unstable and how long some children travel, which is 90 minutes both ways. And it was interesting once I asked and people brought it up, then I knew to bring it up at further PPIE sessions and people would build on it. So I got a better understanding. So there have been a lot of things like that where it wasn't even on my radar to ask, but letting people know, what do you want me to ask? What are the questions was really, really helpful. Okay, so next, bring a handout. Oh, I find it really helpful to bring a form for them to fill in. So first you can get consent, but you can also give them a consent for you to share what they have told you in an anonymized way. But you can also put in spaces for them to share anything that they maybe didn't get a chance to or don't want to bring up verbally, which is especially helpful because I think it's a common problem in PPIE that one or two people are really, really talkative and some people are not. And this is a good way around that. So, especially when you're not prepared for ways to shut down a really emotional soliloquy that someone gives you, it's really nice that other people can say what they want to say, even if it's too awkward to interrupt. And let's see. Yeah, take notes. Ask if it's okay for you to take notes and record. You can record. I've usually been okay just taking notes, but make sure people are okay with that is what I would say. Okay, and then what to do afterwards. Write it up. So the first thing I do is write up detailed notes. So I'll have my notes in a notebook, but then I write up detailed notes for me. And then I synthesize those notes. So kind of bullet points. What does it all mean? And then I often will put that together with what else I've discovered from other sessions and then disseminate that. So you can disseminate that for eChild. We have a website where all the PPIE goes. There's summaries on there from lots of different sessions. You can include it in your publications, in your findings, in your background. It's always really helpful to include PPIE and in funding applications, of course. It's also really appreciated when you follow up with people you've conducted PPIE with. So they like when you come back and tell them what you've learned. And they like to then give you more feedback. So sometimes you can go back and say, I've actually been speaking with other groups and here's what they've said. Have you had this kind of experience? And often people will say, oh yeah, didn't think to share that, and you'll learn a lot more. Also, it's always very good to acknowledge participants in your presentations and publications. They want to, I think people appreciate being thanked and being recognized. Okay, so now I'm just going to give you an example of some things I've learned from conducting PPIE. So I've had a chance to meet with families of children with Down syndrome in regions across the country, from high socioeconomic statuses to low socioeconomic statuses, and in groups and individually. And one of the things I've been trying to understand is school choices. So the choice between mainstream school and special school. And one of the main things I've found is that there are three main factors in how parents choose. So they want their child to be a part of their local community. And what this often means is that they want their child to be able to walk to school and see people they know along the way. They want their child to go down the high street and have people know their name. They also want their child to have access to appropriate resources for both their physical and their learning needs. And they want a school that has an appropriate culture. And one thing that was really quite surprising that I don't think many of us expected was that, so when you talk about school culture, a lot of us think like, oh, special needs, we want to make sure that they're not being bullied. But in fact, I've never heard an example of a child with Down syndrome being bullied by a child without special needs. Occasionally, they'll be bullied by another child with special needs. But what happens often is, oh, sorry, I'll take that back. What happens is the teachers sometimes create a hostile environment, or the administrators, where they don't want to be supporting a child. They'd rather that the child transfer, and they make a family feel unwelcome. And so that is a culture that parents often have to navigate and push against. When a mainstream school, you know, they have an attitude, but you could go to a special school. Why are you here taking up my time? And so that's something that I've heard again and again all across the country. And I don't think we expected, because policy makers and advocacy organizations push so hard for mainstream inclusion for children with Down syndrome, but mainstream schools often don't like it. Okay, yep, just finishing up. So then what do parents want us to know? Oh, and income and social deprivation end up being factors there. That parents who are more affluent are able to advocate for their children more and get access to resources. And this goes back to that appropriate support is the most important factor, and it can happen in either school type. And it's really not a feature of the child. It's all a feature of the individual school. Yeah, so that's it. But I do want to thank the children with Down syndrome and their families who've shared their stories, and the Down Syndrome Association who've funded this research.
Thank you so much, Julia. That was an expert's guide to how to do PPIE. And I genuinely feel like you should write the book. Any questions from anyone? I see. Julie, if you just stop sharing your slides for a sec, I can see.
Oh, yeah.
There
we go.
See more people. Yes, I can see you all now. Any questions in the chat? And I can't see anyone with their hand up, so I'm gonna butt in. How much have you done, because you talked about like kind of the whole in-person thing, how much have you done online, and how do you find the kind of differences, and how do you, because I feel like in person it's easier to kind of get that rapport going, and like bring biscuits and everything like that. So how do you what's your strategies online? What's your top tips?
I would say online. So I've been really fortunate. All my online meetings have been one-to-one, which has been great. So and often it's so much easier because you just like chat with someone for an hour. And you know, it's much easier to gauge the relationship and help them feel comfortable. So I know some people do groups online. I don't know how.
Yeah, it can be tricky.
Yeah.
Thank you so much, Julia. I feel like all of the speakers today have been so fantastic and great. We had Joe really set the scene for us about why, and all his principles about how we should be doing co-production, PPIE, with children and young people. Then we had Louise present on eChild and how it's really been done well in a data-focused research project. And then Julia's guide is just fantastic. So I'm looking forward to seeing that in publication at some point, along with all your other millions of work that you're doing. Please do stay in touch. I have a slide to share on that. Share screen. There we go. Share. So yeah, please do stay in touch with us. Can you see my screen? Yes. Yay. Current slide. And Vish is just going to put all those links in our chat so you can go and check us out. And yeah, thank you so much for coming to us today and for being so great. Thank you so much. And, you know,